This is a redo sleeve gastrectomy for wide stomach and weight gain. She had a sleeve gastrectomy a few years ago. She gained the weight and she's able to eat a lot. You can see the large fundus and also the body, which was confirmed by the barium swallow. The momentum seemed to be attached to the stomach as if no detachment happened before. You can see the staple line at the antrum area. To take down all these attachment of the momentum, and also the adhesions behind. These ligard clips have to be removed, otherwise they come in the line of the division of the stomach when stapler is applied. This is the front of the stomach, and you saw the duodenum also beyond. Do not divide the antrum very close to the duodenum. It has to be divided about 4 centimeters out. They are the duodenal gastric junction. We're now at the fundus of the stomach. There are lots of adhesions which haven't been divided at the back. You can see them. All these have to be detached so that you know exactly where you are before you divide the stomach. All the posterior attachments have to be taken down. It's a very tedious and slow process. You have to be very patient all throughout. This is for people who have done a lot of sleeves in the past and to know exactly what they have doing. Even then, it's very difficult. especially if they have applied a lot of clips. When this is almost stuck to the momentum, and there are a few adhesives which haven't been taken. Those are also being taken down now. You can see the spleen beyond. So all these adhesions need to be taken down. Otherwise you don't get a uniform stomach division. Using a bipolar diathermy in the form of NCL. I think bipolar diathermies are better in this situation, but ultrasonic devices like harmonica also should be okay. When you take all these adhesions, then only you can free the fundus. See now the fundus is no longer folded, the abdomen is much wider, and you can see the staples even at the back of the stomach. Here the stomach seems to be folded because of adhesions, and these need to be divided to straighten the stomach. This is the mid-body of the stomach. All the staples and the ligament clips which are in the way have to be removed. The word gastric tube is introduced, and now the stapler is applied. Here is a tri-stapler black. The stomach is very thick. We may have to use 2 or 3 of these black ones. This is the first firing of the black. I tried to put the purple note, but I felt this may not be appropriate. Therefore, again applied the black. You can see how thick is the stomach. Everything appears to be folded. That's how it is, but you have to go very, very slowly to widen the stomach. Sometimes I may use a 45 so that it may be easier to divide the stomach in a uniform way. Now it's coming into place under the purple. Fold almost relatively uniform, maybe. You can see there are lots of adhesion, the posterior aspect of the stomach. Unless we take these out, can't get a uniform division of the fundus, and the fundus will belong posteriorly. Leave the blood vessels as they are, but these flimsy adhesions are taken down. I have to spend a lot of time adjusting this stapler to get this right, stretching the stomach using this graspers. See, I leave a bit of fundus right at the top so that forms an angle of his. And helps prevent reflux, at least in my opinion. It appears to be a big fundus, but the moment you divide it, it just goes back and it's a small one. And I test it with methylene blue in the redo operation, but that doesn't guarantee the leak, but at least you feel happy that you have done it. The stomach is almost as if it hasn't been excised and has slowly removed through the 15 port site. It may take a bit of time. You have to coax it gently, not pull it fast, otherwise they break. And then they put the stomach in the right position as it is getting deflated. If you did well,